Asia Hospital, Kailash Super Specialty Hospital, and has our own child neurology center in Faridabad. This is a very important topic for postgraduates as we need to differentiate that all abnormal movements are not seizures, and there's no better person to tell about this than ma'am. Ma'am, kindly take over.
Thank you, Dr. Aman. It is such a wonderful experience to speak on behalf of my alma mater, ICH, Nagaram Hospital. And thank you all. Thank you, Dr. Sabharwal, sir, Dr. Praveen, and Dr. Anupam. And a pleasure to see you, Dr. Aman. So, yeah, as you have already outlined, that it is a very, very important topic in pediatric neurology. Because every day we see children, those who are presenting with a seizure-like picture, clinical presentation looks like seizure, and somehow the treating doctor felt it was a seizure, and they have started anti-seizure medications which the child did not need it. So, of course, eyes, well, how frequently you see the cases and checking up with your seniors is very, very important here. So that is why we have taken this topic, and I've tried to put lot of videos so that you understand the picture clearly and understand the semiology and understand what is the difference between a true epileptic seizure between a non-epileptic seizure. So let's start. Our objectives are to appreciate the wide range of disorders that present with clinical events. Looks like seizure, but they are not. Again, I'm going to reiterate on this again and again. So it's very important to take a history. So first of all, if a child is presenting to you with a seizure mimic-like situation, history taking is the key point here. So starting you start inquiring, start taking a very good history, and there lie lot of clues in the history itself where you can differentiate whether the seizure is looking like a seizure or you are dealing with such epileptic mimic. Okay, so they comprise a wide range of entities, and that is very challenging for a clinician. Even at this age, we sometimes uh, find it very challenging, and there is a gray zone where we take help of other investigations also, which I'm going to discuss later on. But of course, seeing the cases and discussing with your elders and taking a very good history is the key. So misdiagnosis is very, very common. Up to 30% of children, kids, they are diagnosed with epilepsy where they are not suffering from SIM. So it is very important to identify here. So clinical assessment is a key to diagnosis. And if needed, we need to correlate these movements with the neurophysiological studies. Okay. So not everything that which is a seizure. Okay. And therefore, it is very important. Yeah, Dr. Aman. Okay. Dr. Aman, did you raise your hand?
No, ma'am, no, ma'am. It was by mistake. Sorry, ma'am.
Okay. So not everything that which is a seizure, and therefore it is very important to consider other conditions before diagnosing. It's a epilepsy. Okay. So it's not moving. There has happened some glitch here. Yeah. I'm not able to move my slide. Can you see my slide moving? हेलो
नो मैम आप लोगों ने
No, ma'am,
स्क्रीन
they are
ऊपर
just
के
stuck.
दोबारा से स्क्रीन शेयर कर लीजिए
क्या कह रहे हो? दोबारा से शेयर करूं?
हाँ जी हाँ जी
ओके या so here we are here. So this is the common picture of the status of epilepsy in children, and it is a very common neurological disorder. It can happen at any age, older in children, adolescents, young children, and of course, we are not going into further details of epilepsy. So, fix. Anyone can have epilepsy. Can you tell who does? And this sweet little kid is saying, I don't think so. So, here lies the key. So the non-epileptic movements, there is a specific age-related particular diagnosis when the age of babies are neonates, when a baby is infant, when a baby is toddler, and childhood, considering the further years like in adolescence and teenagers. So non-epileptic movements in neonates and infants are, I have tabulated here, but I've taken each and every one with a specific video, and I would like to play it maybe twice so that you can have a better picture of the presentation. So first is jitteriness, excessive startle, benign neonatal myoclonus in neonates and infants, shuddering attacks, Sandifer syndrome where there's arching from the gastroesophageal reflux, and older children where there are tics, self-stimulation, paroxysmal dystonia, and episodic ataxia. So there can be episodic collapse, loss of consciousness, episodic staring or altered behavior, episodic limb movements, posturing, and episodic nocturnal disturbance. So there lies the key. History matters, and a very detailed, a very good history and your examination rules out so many things. So first and accurate first and witness. What is the age of the child? So the first table where we have tabulated the age, infants, neonates. Age is very important. Situation. What was the child doing? Whether the child sleeping, or child was sitting idle, or child was engaged in something. So situation triggering the event is very important. What was the child and the adolescent doing when event has happened? So all these factors in history is very important. I think the PGs they should take a very detailed history कि बच्चे का एज क्या था, कैसे हुआ, उस टाइम बच्चा क्या कर रहा था, बच्चा सो रहा था, नहीं सो रहा था, मूवमेंट्स कैसी थी, बच्चा खाली तो नहीं बैठा था, बच्चे ने फीड लिया था कि नहीं लिया था, बच्चे की कोई सिग्निफिकेंट बर्थ हिस्ट्री है कि नहीं है, अभी डेवलपमेंट माइलस्टोन्स कैसे, these all are important. So there could be some potential triggers in like syncope, which always mimics as seizure, where the triggers could be exercise, prolonged standing, getting up suddenly, or any sleep deprivation, which can cause a precipitation of seizure attack. So warning symptoms. So if a child has been to school and was feeling very warm, abhi jaise hot and humid weather tha, the child is feeling very hot and warm, and the vision was gray, and he could hear the muffled hearing. So it could be a syncope. So uske baad, once the child has had syncope, there could be some tonic-clonic movements which parents, teachers, and whoever is looking after the child and will witness the event, they feel that it was a seizure, but it is not a seizure, it is a seizure mimic. So there are some pre-oral symptoms when there is a epigastric rising feeling in tummy or a metallic taste. That could be a pre-oral symptom for a real epileptic seizure. Or in cardiac syncope, if the child had very profound palpitations or chest pain, there could be a cardiac syncope. So was the eyes open or shut? Eyes were one towards one side. Was the child looking pale or was looking blue? And how was the tone of the body when the child presented with the same symptom? Was he stiff? Was he floppy? How the child was presenting? What was the posture of the child? That is very important. A few random jerks that can occur with syncope is very common, but we should not take it as a seizure unless and until we take a detailed history. Or a sustained rhythmic jerking movements. Was there any tongue biting? Duration of the event and how quickly the child regained the consciousness and was able to remember the event is also very important. So stereotypic movement, जैसे बार बार बच्चा is doing the same type of movement which resemble each other. So they are very, very important in diagnosing whether it is a seizure mimic or a seizure. So, barbari bacha, if it is a doing stereotypic movement, there could be a different seizure type or randomly distributed in time, not confined to a particular situation, right? So, here lies the your detection and your good history examination where you can outline what type of movement was it and what I am dealing with. So let's take this video. I'm going to play it. So this is a baby who was non-vigorous, born non-vigorous MSL and required resuscitation after delivery. And this movement was seen in NICU and the doctor was on rounds. She saw these cycling movements and this has happened. So see the movement. There are some rotating seat movements. When the doctor is trying to stop the movements, you can see The right limb is still moving on. The left is also still moving on. So both of the movements are still going on if we are trying to stop the movements. It looks like there could be some pathology related to these movements, but again, we are not sure. We will look for the heart rate, we will look for the movements, what these movements are. It looks like they are not looking normal. So again, so here it is important how to differentiate your neonatal seizures and jitteriness. So this doctor has tried to stop the movements but was not able to do so. But if a baby is jittery, that is a fine tremor like movements when you hold on the baby. You find these fine tremor movements, and when you try to stop it, you can stop it. So that can differentiate neonatal seizures with jitteriness. So here is the second video. See, they are very fine tremor like movements, and when you try to hold the baby, when you cuddle the baby, these movements stop. So that is a good differentiating factor that how to differentiate between a neonatal gypsiness and a neonatal seizure. But again, there is a very gray zone where you have to rely on history and the other hemodynamics like heart rate and other parameters as well. Okay. So the neonatal seizures, the external stimuli doesn't initiate, but yes, gypsiness external stimuli can initiate. Movements, they are irregular and jerky in seizures. There are symmetrical fine tremors in jitteriness. There could be heart rate increase in seizures and could be associated with breath holding in seizures, not in jitteriness. And the movements can be stopped by gently bending or holding the leg or making the baby stuck. But these movements does not stop it seizures. So there are very frequent movements which you see in neonatal units, and the neonatologists, they are not sure what they are dealing with, and your clinical examination and your approach really makes a lot of difference here. So this is again a very, very common problem which we see in OPD, and nowadays parents are very, very aware. They feel, they Google it, so they find lot of moments they are not looking normal. But then you have to see the moments, how you perceive the moments, and then you have to reassure the parents if you find they are not looking abnormal to you. So this is a baby who is 2 months old, no significant birth history, development, there was no significant pregnancy to taste, no significant family history, and the baby had these abnormal movements only while sleeping, right? So can you see these sudden jerky movements seen only while baby is sleeping? So when you inquire these movements, the parents they come to you, so you have to first ask, record the video if possible, and then second, you have to ask the association whether these jewels are associated when the child is awake or when these movements are only happening while the child is baby is asleep. So the parents would say that the doctor only these movements are associated while the baby is sleeping, and they can be seen from few weeks to 6 months. So here it is very reassuring. You should know, you should see the video, and when you feel that this you are dealing with neonatal benign sleep myoclonus, you are reassured. You can tell the parent that these movements are not epileptic. These are simple sleep myoclonus, and once the baby grows up, these movements will go away. All right. So it is a very, very common presentation when the parents come to you and say, "My baby is having jerks. Please see doctor whether this is epilepsy or not." Right. So next video is this baby who has been on top feeds along with breast feeds, and mother is very, very intelligent. She would tell the association of these movements with feeding, and she will explain the whole movements. See how these movements are. So I'm not sure whether you're able to hear it or not. Yeah. The baby has been fed, saying the doctor, I have fed my baby, and the baby is doing a lot of arching of the feet. Whenever I try to put baby on my front, thing, not we don't want the child to get right? So this is looking like epilepsy, this is looking like seizure, baby is doing lot of hurting here, and mother is trying to lie down the baby, and baby is just doing the artist and turning the head towards, then she's trying to do the so if arching or bad constantly after feeding and baby looks, it looks like a seizure, but it is not. So what we are dealing with here is a strong differential of tactical zone when there is arching. You can see very properly the baby is arching and is not looking comfortable. So the baby can tilt his head towards one side and return sharply and they do the arching. If it is not a seizure, it is like so the young children, the reflux with or without vomiting, the events are mostly seen after feeding and they could be arching as we've seen in the video. And the arching of the back and the trigger of the events are the key features that distinguish this disorder from epileptic seizure. So here we don't need to give the child anti-seizure medication. The treatment lies in the treatment of gastroesophageal reflux. So again, this is a very, very common video again, and lot of kids do come from remote places where they are on seizure medications, but finally, when we do all the investigations, we find out this was not a seizure and this was just a seizure mimic, and we reassure parents, and they are all happy because the medicine has been stopped and we are given that. So here, what happened to this baby? Baby was milk fed mostly, was a bit anemic and after having some irritability episode, baby cried a lot. And following the cry, baby hold has hold on his breath and was looked a bit blue near his mouth. And following that, his body turned very stiff for nearly less than a minute. So parents were very, very anxious that doctor, this is looking like seizure. And we have seen our local doctor there and they felt it was a seizure and child has been started off anti-seizure medication. So here you see the video. Baby has been crying, crying, crying. Now has stopped breathing with his lips turned blue. I could not take the whole video of the body because it was not there because parents they do panic when these episodes happen, so it is not easy to have the video, but somehow we were able to catch the video. So I it's not a very good video, but uh once a child is being crying and of course after vaccination, some babies they get so irritated, they cry a lot and following that prolonged cry, they hold on their breath, turns this lips turn blue, and the baby is sick. So this is a typical breath holding spell usually seen in iron deficiency anemia is these babies are more prone to develop this breath holding spell and there could be a genetic predisposition also. So this is a typical breath holding spell. So here your history lies very important that you have to ask parents that whether the child had this moment while he was crying, following the cry, did he was not breathing for a few seconds, and following that was it turned stiff. If it is the case, then you are dealing with a breath holding spell and it is not a seizure. It could be provoked by a trivial injury or a baby's upset. It could happen in preschoolers, toddlers, infants. Start with crying, progress to apnea. This cycle is very, very important. Cyanosis, loss of consciousness and tone, and sometimes they get stiff also. Rarely there is a tonic stiffening, tonic jerking, and they rapidly recover after having this episode and they recover consciousness following the attacks. It could be genetically predetermined or it could be associated with iron deficiency anemia. So we have covered the common presentations of newborns, toddlers, infants. So coming to atonic seizure, so we are not dealing with all the epilepsy mimics. There could be epilepsy also. So we have to strongly take the history examination. There are atonic seizures where there's sudden loss of muscle tone, but these are not precipitated before the child is not crying before the episode. The child was absolutely fine and just had a sudden loss of consciousness or sudden loss of muscle tone. So you're not dealing with breath holding spell because breath holding spell, the key thing is the baby was crying before the episode. So the differentials for atonic seizures, again, we have to take a good history. Syncope could be there. Breath holding spell, again, if the child was not crying, we are not dealing with breath holding spell. Or there could be psychogenic seizure, which usually is not presentable at this stage. So this is the girl. Please do not take videos because I think they are all our patients, so that might be confidential on the privacy of the patients. Right. So this girl was 15 and see the event. So suddenly the drop and the parents, they the child might injure her. They put the towels and finally we had helmet for the child. So here it is not uh, a Bretonic spell because the child was not crying, but suddenly she lost her tone, so it was abnormal. I'm just putting the video so that we understand what is normal, what is abnormal. Again, this was a baby, I think did not take her. Okay, so right. So this was a 1-year-old child who was admitted in hospital, and the doctor called me up in evening saying, "The doctor, we've got this child admitted, and there are some abnormal movements. We have loaded with Levera, but the episodes are not getting better. So see the moments and appreciate the moments are. The baby is absolutely conscious, was a bit excited before that because the parents had wanted to see the facial, a little bit of moving face, lips down, and just some shivering of shoulders as well. If anyone wants to repeat the video, please put in the chat box. We'll repeat the video again. I think I'll play it again. Right. So see the face of the baby. Yeah. See, okay, the child is absolutely conscious, is not getting upset, is having just a shivering of the shoulders and the face, lower face, along with this mouth. So this is the second episode which we can see a bit more closer view. See, yeah, these moments, right? So another video I have got with the similar, right? So these are shuddering episodes. Again, these movements are not epileptic, they are non-epileptic, they look like seizures, but the child here is not losing his consciousness and is just doing for a few seconds and coming. So there are three brief movements of shivering, shaking, affecting head, shoulders, and arms for a few seconds. It occurs when the baby is excited, freezing, or change of position. So see, this baby is so alert and active. Mother has offered a new toy and baby is so excited and see the moments has happened. Sound toy and the mother has squeezed in the sound and you could see the excitement. Baby and when mother, yeah, see these moments? Yeah. Yes, yes, yes. So these are all shuddering moments. Okay. So these are usually seen in toddlers and you have to reassure parents that it will go once the baby grows up. So right. So this was a video which is very confidential when I was a trainee at Bristol. When we started our training, initially we got a call from a region saying that doctor, this is a seizure, and they have shared the video, and we went to a consultant. We described the video, and our consultant told, no, 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 it is not the description which you are giving. Let's see the video first. So is 3-year-old boy who is having his right extended leg a bit adducted, other leg is also adducted, and one hand is near his upper thigh. The left hand is just near the head, and the child is doing these movements very, very frequently, just rubbing both of the thighs together, adducted, doing it again and again. See, you can see the movement, and his face is also looking a bit flushed. And now this movement stops, and the child is a bit sleepy, is half awake, is opening his eye intermittently and closing it. So now he's back to normal. Can you see? Looks like that nothing has happened, right? He's back to himself. Okay? So seeing this type of movements again in another child, this is again a beautiful girl who was lying idle, who was just playing by herself. And mother has noted multiple movements during the day and she was very, very worried. She consulted a pediatrician. A pediatrician has shared this video. See, again, both of the legs are very tonic, adducted, and she's having her hand near the inner part of her thigh near her genitals. And one hand is following that. Mother said that she was a bit sweaty, but she tried to stop her during these moments. She cries very bad. So, what these moments are? Of course, when you see these moments, you will never forget and you will never miss this diagnosis. So, it is very important to identify and pick. So, this is called self gratification in children. It is a very, very common problem. It's so there could be a rhythmic reflection and adduction, and it could be accompanied by a flushed face, and sometimes the child sleeps following the episode. The diagnosis is more difficult if the child is unhappy during the moments and is crying, but the relative frequency is very frequent and the child doesn't lose his or her sensorial. And usually do this movement when bored, when is just playing by himself or herself, or in a car seat in Western countries, or in a high chair, they do it more commonly. Okay, so this is self gratification. So coming to, we have covered the few moments which look like seizures in neonates, infants, in young children. Now coming to the other moments. So this moment I have taken from the internet because this usually is not captured by videos. So this was a press briefing, and this lady was uh, standing just next to the person who was briefing, and she fell down, and can you see her hands were a bit stiff? Then just quickly her legs were raised and she regained her consciousness. So this is syncope. So where your history is very, very important. You have to ask the parents. Sometimes the child is in school, so nowadays there are a lot of cameras in the school, so you can request the parents if they can get a camera recording from the school, and it is very important to differentiate what has really happened. तो यूजुअली पेरेंट्स will say डॉक्टर हम बहुत गर्मी में बाहर मार्केट में गए थे बहुत देर खड़ा रहना पड़ा एकदम से बच्चा नीचे गिर गया 1 मिनट तक उसका गिरा रहा बॉडी टाइट हुई और थोड़ी 1 मिनट में ही वो अपने आप खड़ा हो गया एंड वॉज नॉर्मल तो यहाँ पे वो बोलते हैं हाँ डॉक्टर हमें बहुत डर लग रहा है कि हमारे बच्चे को दौरा तो नहीं था जो हम मिस कर रहे हैं. So it is very important to differentiate between an epileptic activity here or a non-epileptic like syndrome. So your history is very important, where you need to ask the prodromal symptoms. The episode से पहले whether the child had lightheadedness. If the child is young, you can ask whether your vision was blurred or you could hear the muffled sounds, or there was your heart was you were feeling a bit palpitation, your heart was running fast, or did you had sweating, or did you feel a bit of not feeling well? And if there was a symptom like that, or you were standing too long, it was a lot hot weather, then how much liquids you drink every day. So these episodes are very brief with a rapid recovery. So here lies the very important to differentiate whether it is a seizure or not, because the recovery might take a long time if it was not a syncope, and the child could be drowsy for a long time, maybe a couple of minutes, 5 to 10 minutes, and could sleep after the episode, would have headache if that was a seizure. If it was just a plain syncope, the child would have lightheadedness, will have a sweating, pallor होगा, nausea होगा, थोड़ा सा muffled sound सुनाई देंगी, अच्छे से दिखाई नहीं देगा, will fall down on the ground, and following that will regain consciousness very quickly. So that you can easily differentiate based on your clinical history and your predisposing or prodromal symptoms. तो वेजोवेगल किसी बच्चे को बहुत जोर से चोट लगी, या कोई some children they have these episodes when the blood sampling has been done, or they are very scared of seeing the blood. So there is always a precipitating event, number one. Or there are some teenager girls who have just started menarche, the bleeding was quite heavy and the child did not had any food and had these episodes. You have to ask a detailed history here. No, you cannot just say no, it was a symptom. So take a detailed history, how much water you drink, how much you have slept yesterday, how much is the screen time. So you can make lot of your impression from the history only. So prolonged periods, if the child is standing, और देर वॉज अ लाइक बहुत जोर से कोई चोट लगी या दरवाजा कुछ लगा, वी डोंट नो, एंड द चाइल्ड जस्ट कोलैप्स्ड ऑन द फ्लोर, और देयर कुड बी एनी फियर, कोई स्पीच देना था उससे पहले ही द चाइल्ड कोलैप्स. So there's all are looks like there's a vagal, but you have to rule out a cardiac syndrome when if a child is having syncope while exercising, whether the child was playing a football and had a syncope, or while supine the child had syncope, so there you have to rule out cardiac syncope and you have to do a cardiology further investigations to rule out same. So it is a good table. I think you might be asked in exams. So what is the differentiating feature between seizure, syncope, and breath holding spell? So precipitant in seizure could be sleep deprivation, since we have already discussed. Breath holding spell, always there would be a cry. Premonitory symptoms could be there in syncope. Of course, in seizures also there could be, but there is a very thin line. You have to see what pre-oral symptoms were there, which we have already discussed in temporal. There could be epigastric, some discomfort, or there could be metallic taste. So here you cannot just say there could not be a premonitory symptoms. There can be. Syncope में dizziness, loss of vision, pallor, nausea, which we have already discussed. Consciousness थोड़ा सा टाइम लगता है निकलने में in seizure, but दोनों में फटाफट से consciousness it comes up. There could be clonic jerking in every. So जहाँ पे clonic jerking है, it doesn't mean that the child had seizure. You have to rule out what you are dealing with. Recovery is very quick in syncope and breath holding spell. पोस्ट इक्टल सेडेशन जो मैंने बोला फटाफट से रिकवरी नहीं होता, इन सीजर इट कैन हैपन, इट टेक children they take a lot of time, and of course if you are not sure, go for a EEG neurophysiological testing, and there you will find some interictal in between interictal discharges in seizures, but it could be normal in syncope and breath holding spell. So psychogenic seizures, it is called paroxysmal non-epileptic seizures. They are functional, they are psychogenic, and it usually occurs in adolescents. It is usually the semiology is a bit it gradually onset hota hai. The building up of motor activity is also gradual, and there could be a rotatory limb movement, but it is a very spectrum. You cannot say this specific movement is there. But another distinguishing feature is that the there could be prolonged attacks and there could be varied motor presentation. कभी बच्चा ऐसे हाथ हिला रहा है, कभी ऐसे. This is not the same repetitive type of movement as we see in seizure, and lack of oral trauma and the lack of post-ictal. After the episode, the child usually sleeps in a seizure attack, but he will not be sleepy or not feel sedated if there was a psychogenic seizure. So these are two movements which we were not sure what these movements are, and parents were very educated. So what we have done finally, we did a prolonged video EEG recording of nearly 24 hours, and we could not find any EEG correlation with these movements. So we labeled it as they are non-epileptic movements. So finally, we found see the girl is having one movement more, another one is a little bit less, and her pelvic floor is also moving. And the parents are saying, breathe nicely, breathe, अच्छे से सांस लो, अच्छे से सांस लो. And she's saying, हाँ मैं ले रही हूँ, हाँ मैं ले रही हूँ. She's not losing her consciousness here. So again, you see the movements here. Upper limb movements, jerky movements, and lower limb hip thrusting, and the child is awake and has stopped. So sometimes you are not able to differentiate whether it is epileptic or non-epileptic, so you have to do a prolonged EEG to differentiate. So again, in young children or school-going children, you can find that the child got blank for some time and further regain consciousness within a few seconds. So teachers tell, आपका बच्चा बहुत daydreaming कर रहा है, he's not attentive in the class, and you don't know whether the child is having absence seizures or a daydreaming. So absence seizures and daydreaming may you can clinically rule out by doing a simple hyperventilation test in OPD, where you ask the child to blow a paper for 3 minutes. And if it is absent seizure, then the child would be turning blank for a few seconds and again coming back to normal. So this is a girl who was suspicious of having absent seizures. We asked her to blow the papers. She's blowing the paper. This is hyperventilation test. See, now the child has just stopped blowing the paper and was just moving her hands, and again she started. So this was the absence seizure when it was precipitated after she started blowing on the piece of paper. So you can simply rule out by doing these simple tests in OPD, right? So this is a very young boy who is very good in studies, and parents were like, uh, he had lot of coaching, tuitions, and lot of activities back to back schedule with his academics, and very like good academic boy had these moments, and he came to me, and parents both were doctors and they were not sure what these moments are. So 14-year-old boy, we see the twitching of face on either side, left and as well as right also. With the facial muscles also twitching and eyes also twitching. Yeah. So you have to ask a detailed history, whether how long the episode was the loss of consciousness, and following the episode, how the child was doing, and that all makes you delineating what you are dealing with. So here it was a motor tic only, whether it was associated with eye blinking, facial grimacing, shoulders shrugging, because we could not take the video this behind below his face, and there could be sometimes neck movements also. They could be exaggerated. So sometimes we ask parents that They are inside the consultation room. We open the door and we ask the child to sit outside. And we try to observe the moment how the child is doing. And sometimes when you're trying to talk to the child, these moments stop. When you distract the child, these moments sometimes stop. So they are exaggerated by anxiety, excitement, or anger, and consciousness is preserved, and child can briefly suppress the movement. So here lies the key. If you talk to the child, sometimes they are distracted and they stop doing these movements. So this is not very important. So you just from occipital lobe, you can have some visual phenomena, and from temporal lobe, you can have behavioral arrest. Of course, it is again a gray zone whether your child is having a daydreaming or a behavioral arrest. So you have to take a good history, a semiology, how the movements work, and that can make you going through a few differentials, and then you can investigate further if needed. A preceding aura is important. So here we are of course not sure if you're dancing to a dubstep. It is a dance when you are just doing an individual street dancing. So you don't know whether you are having you're dancing to a dubstep or having a seizure. So it is not very easy to delineate, but of course, reiterating again, same, doing lot of good history and a good examination makes you feel confident about your diagnosis. So of course, all seizures are not same. So this is a boy who had bilirubin encephalopathy and developmental delay, microcephaly, and this child had very bad, painful moments when he was disturbed, and he was hungry, constipated. See these moments; they are very tonic moments, and the child is very upset, very tight lower lips, a bit of arching, and it's crying. So this happens for a couple of days in the child get back to normal. In between these episodes, when the child is having this episode, the body is totally stiff, and usually mother say कि जब constipation होता है या जब कुछ बुखार है या फिर बच्चा unwell है भूखा है तभी movements ज्यादा होते हैं. So these are not epileptic. This is dystonia. Again, I have brought down two beautiful videos where you can see this baby is absolutely happy and is just doing these jerky movements while the child is playing. Parents were very anxious and were very worried with what movements are and see these movements. This baby had both asphyxia and was a bit upset and see that a jerky movement. He happened and his elbows were flexed. Absolutely happy while having the moment. There was no cry, nothing, and it looks like there was no like typical pattern of any epileptic seizure. But of course, you have to take a detailed history. There was no significant birth history. The child has normal development and was sleeping absolutely fine. So we were not worried about the left one, but of course, the right one was not looking as normal. So this is again the same child whose movement was captured in camera. The left baby. So we do, yeah, yeah. So he's just playing and he's just moving his neck like that. This is not looking worrying for us. So we've taken detailed history and we could say that these movements were not epileptic. So of course there is a lot of the another spectrum nocturnal disturbance where there are a lot of seizures, which I'm not going to talk about, but there could be confusional arousals, parasomnia, sleepwalking, narcolepsy, night terrors, sleep myoclonus, which we have already discussed in babies, and it can happen in young children and adolescents as well, and periodic limb movements of sleep. So here it is very, very important to differentiate, take the good history. Parasomnias are defined as undesirable motor, autonomic, or phenomenon that occurs during the sleeping state only, and it usually happens in first half. Nocturnal seizures can occur more than once a night, and it is a key to differentiating factors, but it is sometimes very difficult to differentiate whether we are dealing with epileptic activity or we are not dealing with epileptic activity. So you have to do a prolonged video EEG where you capture the whole sleep and you see the neurophysiological correlation of the movements. So night terrors, nightmares, they look like because the child wakes up terrified, was deeply asleep, and is not getting comforted by talking to the parents or they are offering milk, nothing. The child is totally crying and has again gone to sleep. So sleep talking, sleep waking, walking, and rhythmic limb movements, they all are non rapid eye movement parasomnia, but again, it is very difficult. So nightmares again, the child is waking terrified or upset and responsive to comforting, and they can recall a scary dream which differentiates from night terrors. So seizures, how you differentiate? It's a very again a gray zone here. So seizures could happen throughout night. Parasomnia usually once the child has gone to sleep first third of night it happens mostly. Stereotypic features happen in seizures, but in parasomnia is not observed. Duration is very brief in seizures, but parasomnia, sometimes they are more prolonged. And memory is again a gray zone, so we have to go for a video EG to correlate these moments. So this is a good flowchart which we have taken from NICE guidelines. So infant in sleep, sleep, neonatal sleep, myoclonus, toddler night terrors. So I think here we स्लीप के साथ रिलेटेड है तो सैंडी फर्स्ट सिंड्रोम है स्लीप में है तो मायोक्लोनस हो सकता है नाइट टेरर्स हो सकता है और स्लीप डिसऑर्डर हमने डिस्कस किए फीवर है तो इट कुड बी सिंकोप मूवमेंट्स है तो पैराक्सिस्मल मूवमेंट डिसऑर्डर्स हो सकता है पेन या शॉक है तो सिंकोप हो सकता है हॉट वेदर है तो सिंकोप हो सकता है अगर बच्चा बोर हो रहा था वो going for a bedtime was just playing by himself so it could be a self gratification so there's a correlation एंड एक्साइटमेंट और इमोशन में कैटाप्लेक्सिक कई बार बहुत जोर से हंसते 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 बच्चे एकदम से नीचे गिरते हैं एंड that's it. I think that we are. I just try to put multiple videos so that what I talk gets clear. And once you see the video, you can next time if you see that thing clicks on your mind, and definitely you can discuss with your seniors. And that is the main key of diagnosing it because once your eyes see, you will never forget. Whatever theory we teach you, it is important, but seeing the child and making the videos and discussing with your seniors is very important. The final slide is I may be shaking, but it is not a seizure. And here we conclude with our talk of today. Thank you so much. I'm not sure how much we were able to take in, but I tried to make it more simplified, and you're more than happy. I'm more than happy to discuss this further. If you can contact me, you can take email from Gaurav. We can discuss. Dr. Man?
Thank you, ma'am. It was a very nice presentation. Very simple, very informative. We have
Hmm.
two questions in the chat box. One of
Huh.
the participants is asking, "What do you mean by pallor in the premorbid symptoms of syncope?"
Acha, okay. So that means pallor in syncope, there could be the fish could be like looking a bit pale, and there is sympathetic overactivity, and that is a reason of having paleness before the syncope happens.
Yes, ma'am. There's another question asking, "How do you differentiate motor tics from focal seizures and also shuddering attacks?"
Yeah, it is, of course. Again, so let's discuss about motor tics and shuddering. Sorry, shuddering and focal first, right?
Yes,
So
ma'am.
focal and shuddering. Shuddering was when the child is a bit excited, and you could see a face, a little bit of flexion of a neck, and a little bit of tremor, a fine movement like shaking movement, and then it is gone just in a few seconds. So there is not any focal rhythmic stereotypic movement as seen in seizures, and there is a predisposing factor when the child is a bit excited and is doing these movements. Again, the age, of course, is very important. Coming to motor tics and what was that second? Sorry, tics and focal seizure, of course. So tics and focal seizure, when a lot of time when we see a child with motor tics, you try to talk to the child and they sometimes stop doing it. The distraction makes the child stop these movements, and they are absolutely doing this. And once they're sitting idle, they will do a lot. And lot of times, once we distract them, they will stop doing it. So that is a very key important point here to differentiate. But sometimes you struggle to differentiate between a seizure and a tick. So here, when you need to go for EEG testing, if you are not very sure about your diagnosis, then you need to have a neurophysiological correlation of these. And of course, if any, you have to take a detailed history about the child's academics, and if there's any child is not enjoying his classes or the classes are going too overwhelming. The age is important. So all that factors make you understand what we are dealing with.
One of the attendants also asking whether dystonia is a seizure mimic or not, and wants to know the difference. What is dystonia? Is it a he was asking, is it not an epilepsy or a seizure mimic?
So dystonia is actually a pyramidal movement. There could be paroxysmal movements when we seriously struggle to differentiate whether we are dealing with dystonia or a seizure. But dystonia, as again, I would like to reemphasize, the parents will tell you that, of course, your history is important here, and they would tell you that these movements are precipitated when the child is bit upset by any external factors, could be fever, if he is unwell, constipated, or the child was very hungry, or there could be any precipitating factor is like upset by any of these above, and the child could have these movements. So when it is very tough to differentiate sometimes, and senior people, of course, they sometimes struggle to differentiate whether we are dealing with a tonic seizure or a dystonia. But taking a detailed history and correlating with the predisposing factors, you can delineate the both of the etiology, both of the diseases.
One of the attendants is asking to please kindly repeat the last slide, which had a video of a child with opistotonic posture with a red dress. The last
Okay,
slide.
next question. Red, red slide. This one, last, this one, yeah. I think this one, right?
Yes,
Dr.
ma'am.
Amar? Hello?
Yes, ma'am. Yes, ma'am.
He's a very cute child who had, to see, it, you will see that the child is having a lot of pain by loving these moments, and his whole body is pain. So very detailed difference. It is like, we can easily say it is a kind of people. But of course, your expertise and in the moment with lot of ideas, you can appreciate that this is not looking like a film. And of course, it is possible to treatment. I think Dr. Aman, if you have a lot of questions, that means your talk was interesting.
Definitely, it was very interesting. It has gathered a lot of questions from the audience and they're liking it.
Anna? So I'm
Yes, ma'am.
happy because I am so happy to answer all the questions because that means that
You're listening very nicely and paying attention. Someone is
any other
asking
question?
seizure
Huh?
mimics versus epileptic mimics. I didn't get the question, but someone is asking about seizure mimics versus epileptic mimics.
It should be seizure mimic rather than epileptic mimic because you will not say it is epileptic mimic because they are there should be 2 episodes before you say it is epileptic. It should be seizure mimic. That was something which I realized it later.
Well, I think that answers most of our questions. There will always be more questions, ma'am. They are wanting to discuss more, but I think it's too late, and I think we should call it an end by now.
Yeah. Thank you so much. And I'm more than happy to discuss later also if you need any doubts or any clinical presentations. We can have all the time to talk about it. Thank you so much. I have really tried to make it interactive, and of course, seeing the videos only makes us understand, isn't it? No other thing can make this topic more understandable.
Rightly said, ma'am. Rightly said. Thank you, ma'am, for sparing your time. Thank you for this enriching talk. We are very glad that you gave us this talk. Thanks a lot, ma'am.
Pleasure, pleasure. Thank you, and very good night.
Good
Bye.
night, ma'am. Good
Thank you,
night.
Dr. Anshu. Good night. Thank you, Dr. Aman.
Bye.
Good night, Gauraji.